and welcome to another episode of the Cancer Now What vodcast, sponsored by Arizona Center for Cancer Care. My name's Jenny, and I'm so happy to be joined in studio today with two physicians who are going to talk to us about breast cancer awareness. One is Dr. John Davis, who is with HonorHealth Comprehensive Breast Center of Arizona. The other is Dr. Oren Tessler, who is with Tessler Plastic Surgery. They've also brought with them a very special patient who is going to share her experience with these doctors as she went through a breast cancer journey. Annie, hi. Thank you so much for being here. We're so excited to hear your story. So you know these two guys pretty well.
Pretty well. Yeah, I do.
You want to tell us a little bit about your story?
Sure. So I was diagnosed in July of 2021. The nurse practitioner, and she contacted me that day and said, you need to have a biopsy. And she said, I'm going to send you to see Dr. Davis. She says he comes highly recommended. She goes, that's all he does is he specializes in breasts. And that tumor was bigger than we thought. And I don't know. I have to have Dr. Davis explain it. It's the FISH testing. But I actually started out being a HER2 negative. And I wound up being right on the cusp of HER2 positive, I think. And that's why I had to have the chemo.
You know what? Let's actually take that moment to defer to Dr. Davis, if that's okay, because we hear these things all the time, right? HER2 positive and, you know, the genetic testing and all the things. Can you walk us through from a clinical layman's perspective on what's going on here?
So in general, anybody who has breast cancer automatically qualify for genetic testing. So there's about 8 or 9 genes specifically that target breast cancer, and a fair amount of other genes that target other cancers. So I do a large panel that looks at the breast cancer genes, but also look at the other cancers as well. So if you are, and depending on which mutation you have, depends on kind of your risk or elevated risk of breast cancer or potential breast cancer later on. So that's why we essentially do kind of those larger panels just to kind of see. But what we found out is that about 10% of patients with breast cancer only have a mutation. So majority of the patients that come in with breast cancer do not have mutations, and they kind of end up in these situations where they either qualify for a lumpectomy or mastectomy. To kind of go into the receptors and things like that. So really there's 3 different receptors that we look at overall when we deal with invasive breast cancer. So we look at estrogen receptors, progesterone receptors, and another one called HER2. So estrogen and progesterone are kind of like what I usually say is like a grade on a test, so 0 to 100%. And it just tells you essentially how much of that cancer is covered with those receptors. So in general, kind of everybody produces estrogen and progesterone. What we find out is that a lot of women in the postmenopausal phase take this hormone replacement therapy. We can't necessarily say that, hey, this led to the cancer, but we say that this kind of contributes to it growing. The kind of tricky one is called HER2, HER2, and it's another receptor that's on cancer. If that is positive in general, then you automatically do get chemotherapy. So there, you know, depending on which lab you send it to, some will test for the HER2 stain. And usually what happens is after we do search, so we'll do a biopsy, they'll come back and they'll let us know that it's HER2 positive or negative. And then after we get done with surgery, we send everything back to the lab to get reanalyzed. And then at that time, they will let us know if something's changed or if it was the same. You know, if we kind of think about it, if you have let's say you have a 5-centimeter tumor and you get a sample of it or a corneal biopsy, you're really only getting a representation of what that is. So certain areas may have certain receptors and certain areas may not have it. And that's kind of the situation with this case, is that the area that was sampled at first didn't have it, was HER2 negative, but the final pathology, kind of when we take a look at the whole thing, was HER2 positive.
Okay, so she had the surgery first and then finds out that she has to have chemo.
Yes.
Okay, and then when did you come into the picture, Dr. Tessler?
I think the consult happened when you had already decided you were going to do a lumpectomy at that point?
No, I didn't have the genetic testing back yet, so we talked about both options.
I try to stay out of the cancer decision-making algorithm, and I try to defer to Dr. Davis so that there's no interference. And then after that, based on what they choose, we can go over the different options, what they can expect, the pluses and minuses. And so normally we get it right after the diagnosis so that they can discuss potentially what they want at the end point from the beginning.
Okay. And then is the surgery that you do after chemo, or is it like, are you in the OR with Dr. Davis? Like, how does that work?
Often we do it at the same time. It depends a little bit in terms of what they need. I think in Anne's situation, there was a little more confidence that the nodes were negative, so that makes it a little bit easier for us to go in. And then, it's a collaborative decision. If it's going to be the same time, if we're going to do a delayed reconstruction, if we're going to do it in steps where I might go in with Dr. Davis and then put in expanders or something there to keep us in position for when we get the final results, or if we can just do it all at once, which is the hope, which is what we always want to do. And that was what we were able to achieve here.
That's amazing. So you had these two surgeons in the OR with you, making sure that everything went exactly as it needed to. And that's comforting that you got two specialists.
Absolutely. Like I said, I was so blessed, and I still am blessed to have the team I have, because, from my oncologist to my radiation oncologist to Dr. Davis to Dr. Tessler, it's like, I had my team. I said it to my husband. I said, well, I got my team after I met with Dr. Tessler. I said, that's it. I'm good now. because I trust them with my life. They are phenomenal. And it was like, it was kind of like having a wedding planner. I didn't have to worry about anything. They were Johnny on the spot. It was just, everything just has always gone like clockwork for me with both practices. I think
that really says it right there when your doctor jumps in to make sure that you're getting scheduled at the right time and the right place for you.
He calls me. I'm like,
I think that's the place you want to be. For sure.
Absolutely. So, he treats you. You're like, we're the same people. We just have different careers, right? And it's, it's kind of like I told him. When I was getting my chemo, one of the nurses there had said that they were having problems with the port access. And so she had said, she goes, who's your doctor? And I said, Dr. Davis. She goes, oh my God. She goes, let me tell you something. She goes, he came here, and she goes, he listened to us, and he listened to our concerns and what our frustrations were. And she said he took his time, and he listened and he explained. And she says, you don't see that in a lot of doctors. And I said, no, I know that. My back history, I worked in surgery for years, back in the 90s. I know that. And so with both these guys, I just always, whenever I'm with either one of them, it's just kind of like I'm sitting around having a cup of coffee. There's no, and I don't ever feel like I have to, like there's a stupid question, if I don't understand something. They're very, quick to explain it, and
it's amazing. It's amazing. I'm so glad that, and I'm just to acknowledge that your outcome was so good.
Oh yeah,
and that
blessed.
We're so grateful that you are able to be with us, and
blessed,
and that it went that well, and that you had these amazing guys helping you. So so let's talk a little bit about reconstruction. So you did mention that you can, your patients have to choose between a mastectomy or a lumpectomy, but there's different types of reconstructive surgery. Can you tell us a little bit about that?
Sure. It's there's different generations of what is in vogue and not, and what's popular. It's a big lecture that in and of itself. But basically, there are two main lines of reconstruction. One is prosthetic based, and one is autologous based, which means using your own body. And then within that, there are multiple branches that come out, and each has its own advantages and disadvantages. And some is more of an investment with delayed gratification, and some is more for immediate. So really the decision on where you're going to go, a lot of it was very important, is to see where the patient is at that moment in their life and try to figure out what works best for them there. And also to give them, this is not jeopardy. They don't have to make a decision right away and then they can never go back. You're trying to also maintain different options in the future if their situation never changes. With Anne, it was great because, first of all, when you're working with an amazing breast surgeon, you know that what you're going to get is of the best quality. Like in most of the studies we do in the literature and reconstruction, when we look at outcomes, we've had many arguments about this. So one of the factors that you have to consider is the oncology surgeon, right? But there's politics to that, so we normally don't touch it. But that I know if I'm going to get a dual lumpectomy with Dr. Davis, I know I'm going to get good blood supply. He's aware of the anatomy, probably sensation preservation. The flaps are going to be thick and healthy. That was the perfect option for her, and we went there, and so far it's been a great result.
Dr. Davis, can you tell us a little bit about the choice between mastectomy and lumpectomy from a surgical perspective?
Yeah. I think the main thing when we kind of look at this is kind of looking at kind of the breast size compared to the tumor size. It's kind of one of my main things. So everybody that comes in, I always make sure they have a mammogram, make sure they have an ultrasound, and I usually send them for MRI. Just to go back real quick. So I think
please.
a lot of people, I wouldn't say a lot of people, but a fair amount of people come in kind of as you have before with just the ultrasound. And I think that that's a disservice in general. So I think that everybody, if you're average risk, every woman should be getting a mammogram at the age of 40 every single year. The reason with that is, and I always explain to patients, so MRI, mammogram, ultrasound, all kind of have the same common goal, but they do it in different ways. So mammogram is like an X-ray. If you get an X-ray of your leg, you kind of see the calcium phosphate. The main thing is really those calcifications. And we know that the calcifications can be DCIS or kind of this non-invasive cancer. So that is what ultrasounds don't pick up, or MRIs. So mammogram is kind of by far, if you had to get one test, I would say get a mammogram. That's the main thing. Yeah. Ultrasounds, really you kind of get some definition with that, so you can kind of see the outline and different, borderings and things like that allows us to say, all right, this is lobulated, or it looks, anechoic, hypoechoic, things like that. And then the MRI is really kind of this, I wouldn't say superior, but it uses contrast, and it helps the enhancement with everything. So when you're talking about your cancer at first, so it may look like two different areas, but when you go in, it might be a larger area overall. So mammograms at the age of 40, kind of going from there. So I make sure I have kind of all of my imaging, so mammogram, MRI, ultrasound. And then kind of, on a broader scale, when we look at it, I'll say, all right, how far is it from the nipple? Can we keep the nipple? Do we have to take the nipple? And then once we identify, if the breast or the tumor to breast ratio, then that's when we kind of have the discussion, with the patient and see what the best plan is from that. Some patients come in and they really just want a lumpectomy, there are options we can do. We can kind of have some oncoplastic rearrangement and things like that with the plastic surgeon. Other patients, just the tumor is too large for their breast, which kind of leads us down this mastectomy route overall. So that's kind of the main thing when I'm looking at this, is how large is this cancer compared to how large is the breast.
Okay. And it sounds like you have that conversation very openly with the patient so that they can really be a part of that decision-making process. It's not just, clinically, this is what we have to do. We can talk about why, and we can get there in a way that the patient's comfortable.
And having that conversation up front is the important and main thing that I always try to do.
That's amazing. For Annie's situation, we had surgery and then chemo. Mm-hmm. Did you have radiation? Mm-hmm. Okay, so when does radiation come in?
Yeah. So it's this. So if you're doing a lumpectomy, you usually, in general, what I'll usually say is in general, you usually always have radiation with that. So in kind of the ideal world, and there's variation. So you can get chemo before surgery or after surgery, depending on how large the tumor is, the ER/PR status, HER2 status. But if we're just kind of board answer, so usually the patient will have a lumpectomy. If they need chemo, then they will get chemotherapy after that, and then radiation following that.
Okay, and then if it does end up recurring down the road, do they have to do it in that order again, or you just reevaluate the whole thing as a brand new situation?
Yeah. So with so you're only allowed so much radiation kind of in a lifetime. So if you have radiation already from a previous cancer and they have a recurrence in that same breast, then we usually have to do a mastectomy at that time.
Okay. Yep. And after surgery, any side effects from your perspective, or things that people need to be aware of?
No, I think Dr. Davis said in a good way. What you're trying to do with managing expectations is you try to, first of all, when you're making the decision with the patient, you're trying to make sure that not only in the immediate does this sound attractive to them, but they think about it. It's important to involve their family as well. That down the road, as you said, in 5 years, that they're going to be comfortable with their decisions as well. And sometimes when you're in the middle of finding out something that's not a pleasant, it's not pleasant news, you might say just get everything out fast, but that they should do very well in the future, and then they're going to be left with the results of those decisions. So we try to keep everything calm so that we can be as rational as possible, even in a highly emotionally charged situation.
So did you, anything, post-operatively, any short-term, long-term side effects that you experienced, Annie?
I didn't have to have drains or anything, so that, was good. I had not a problem. I had no problem with my recovery. I just breezed through it. And he was talking about, the breast, the radiation and stuff. And I remember coming in to see him, and he says, I'm not even going to look at those until a year after you have radiation, because, there could be changes. And I'll tell you that he did an amazing job. I couldn't be happier. It's like, I'm just so blessed. And, but I didn't have any problems with my recovery. Not at all. I just breezed through it.
And how long were you in the hospital?
I wasn't. No,
It was all outpatient.
Yeah.
Wow.
We were at Greenbaum. And
That's amazing.
yeah, these two work really well together. I haven't been in an OR with them, but I've been with them enough to,
Well, you were, you just don't remember.
I was, yeah. But, the day when I had my surgery, I know I was like the last case, that day. And I know, the nurses, they want to get going and stuff. And I remember Dr. Davis showed up, and then Dr. Tessler came in, and, he's doing his stuff, drawing all over and doing this, and he's talking, and all of a sudden he says to Dr. Davis, oh, here, you want to make your mark? And he goes, right there. And then he gives him back the pin, and I'm like, oh.
That's amazing.
But they just, I had no, I was very, because I didn't have drains, and I didn't have, everything was dissolvable. It was just really it was a cakewalk.
That's
for
amazing.
me when it came to the,
People do not say that when they go through a cancer journey.
The
surgery was
But
manageable.
surgery was, I just did really, really well.
That's amazing.
Yeah.
And full range of motion and all
yeah.
that stuff.
Yeah.
all
And
good.
I was really, once I could start, like I do Pilates, and I actually finally got a Pilates machine in my home. And so I knew that range of motion after surgery and after radiation was, and so I didn't lose any of it.
That's amazing.
I bowl every Wednesday night. I'm, nope, I'm good. But you have to do that. You can't just not move. You've got to get up, and you got to be a willing participant in your recovery.
Yep, absolutely. So what are the latest and greatest treatments in breast cancer treatment, and what are we excited about from a surgical perspective?
I think this might be kind of going to his territory a little bit, but when we think about breast cancer and mastectomy, so in general, kind of when we do mastectomies, we have nipple sparing mastectomies, total mastectomies, skin sparing mastectomies. So essentially kind of some variation of keeping the nipple or removing the nipple. When we do nipple sparing mastectomies, we essentially kind of preserve the entire breast envelope, including the nipple. Anytime you do a mastectomy, all the nerves are essentially gone at that point, and you have no sensation at all. Usually what we say is that the nipple doesn't get erect, doesn't have any feeling or sensation or anything like that. Kind of one of the main things really is, and Dr. Tessler's group, is kind of one of the pioneers in kind of doing research and things like that with it. But kind of this essentially kind of reattaching one of the intercostal nerves to the nipple to help with sensation. There's not a lot of studies, but from the limited studies that we do have, and from patients and things like that, it's about a 50% chance of actually having nipple sensation and preservation at that time.
Can you speak to that a little bit, Dr. Tessler?
Yeah, sure. A mastectomy now is not the same as a mastectomy before. And a lot of that has to do with, the breast oncology field. Plastics has contributed as well. And in terms of the reconstruction as well, like the options are, they're evolving all the time. And so you'll see sometimes people that they had their mastectomy reconstruction 14 years ago. It's not that long ago. And then they'll come in and they don't like the result. And, they said, my friend just had it and they had this. And you're like, it was a different world. This is not anyone's fault. It's just a difference. The cars were different too. I remember the cars you had to, bring down the window like this. They drive themselves now. So it's very, very different. So there's been a lot of advances, and there's continuing to be advances. And I think one of the things that's great for women in what's being advanced is understanding how to get the body to cooperate. Right? Everything we do in medicine is trying to ask the body to do something. Right? And so the ability to take from one area, even harvesting fat and treating it in a way, right now there's enhanced viability fat grafting, and that uses a surfactant that's been used for 60, 70 years in transplant to basically protect the cell membranes of the fat. So you used to not be able to reliably just do perform liposuction, purify that fat, and inject it, and have it incorporate into the breast. And now we have 300% survival rate of transferring just fat cells.
That's amazing.
So, I mean, think of how that changes the game. With nerve grafting increased sensation, there actually is data. The data is not robust. Part of the reason the data is not robust, and this is something in reconstructive surgery, especially microsurgery, is so difficult, is that the numbers are not, they're not that high. So it takes a while for that data to come out. We don't have 50,000 patients. There's very few people who even perform this surgery. And very few, there's some breast surgeons that don't want to waste the time to do it in the first place until they have the data. So you need someone who has a mind for innovation, like Dr. Davis, who'd be willing to do it with you. And then you have to go through the process. It's something that, in our office we called SPARE, which was an acronym, which was, sensory preservation after reconstruction. And we trademarked that, and basically was trying to, at the time mastectomy, locate the nerves that innervate the nipple, dissect them back, then find out where they insert into the areola itself, and mark that. Then they do their mastectomy, and then we just use a simple nerve graft that for a while was provided to us by the company free of charge to just kind of do it. It's the worst case scenario is there's disappointment, but best case scenario is you preserve not just protective sensation, but the very specialized sensation of the nipple. That sensation is very unique. And I think for a lot of women that have had it, they talk about that difference being that final step towards feeling really complete. We've done 3 or 4 right away in the beginning, and I think probably about 20 have been done now here in Arizona, in the Phoenix area, for sensory preservation. It's still, though, very specific to certain people, because those nerve grafts, if you have an extremely large breast where the nerve's traveling a long distance, it has lesser outcomes. Most of the data that shows its value is less in terms of, very fine 2-point discrimination or SW filaments, but more in terms of the speed of recovery. It comes in more robust, more fast, and feels more normal. And I think we'll see more data. It'll be refined more as people push for that next level. I think there'll be more and more reasons to consider this.
Yeah, that's exciting. That's really exciting. I'm excited to see what develops over the next few years, and you'll have to come back and tell us all about where it goes. It's exciting. Mm-hmm. So I just want to wrap up. Annie, what would you tell someone if they are newly diagnosed with breast cancer?
The first thing is that, fear is our worst enemy. And when you're faced with a diagnosis of anything, I mean, you're there. Fear is there. And you don't run from it. Run at it and do something about it. The day that I, so I remember when after I got off the phone with him, and my husband was gone at the time, and I remember walking into my house. And I just remember just the quiet, and it was just deafening to me. And I just stood there. And at that time, I had so much respect for that silence. And I know that sounds really weird, but the reason I had respect for that silence was because I was given a second chance to do something about my diagnosis. And so many people take that walk through their door, and they don't get to go back and have that chance. So I just tell people, don't, I was so lucky to be a stage 1, but I don't care if I'm working with the girl right now. I told you I'm cold capping her, and she's a stage 3, but they have made so many advancements, whether you're a stage 1 or a 3 or a 4. I mean, they didn't have that stuff when my mom was around. And you can't fear it. You have to go at it. I mean, you got to do you, and you have to do what you feel is right for you. And I know there's a lot of people that don't have the support. We were talking about that. I mean, my husband is my rock, my family. I mean, that's my everything. But there are people that don't have that in their life. But there are organizations out there that can help you. And if you don't know, ask your doctors, get in those positions. Don't run away from it. And if you need somebody, call me. I'll go with you. You got to stay on top of things. There's organizations out there. I think women are entitled to a free mammogram every year. Even if you don't have insurance, you can go get that. And there are programs out there that can help you through this.
Yeah.
So for me, it's just like, okay, I got a second chance at this. So I took it and I ran with it, and I ran to him and I ran to him, and it worked out. But like I said, I'm not exempt from it. It could reoccur. I hope it doesn't. But if it does, I know, like I said before, they're going to catch it early, and we'll just go at it again if that happens. But I hope it's not going to happen. Yeah.
Well, thank you so much for that perspective.
Yeah.
That really means a lot.
Yeah.
Anything else you wanted to add before we wrap up, or?
No, thanks for having us.
Okay, we're so happy to have you. Dr. Davis.
Thank you.
Thank you so much for being here. And thank you so much for watching another episode of the Cancer Now What vodcast. If you would like more information on Dr. Tessler, you can reach him at TesslerPlasticSurgery.com or 480-210-7220. If you'd like more information on Dr. Davis, you can find him at azbreastcenter.com, area code 480-907-7551. Thanks so much, and we'll see you next time.